So we're going to be looking at my model for clinical outcomes assessment and practice today, involving one of my athletes here at Clinton High School. And in this case study that I'm going to be presenting to you today involves an 18-year-old senior baseball player, plays first base and pitches, complaining of medial elbow pain in his throwing arm. Started about a week before he came in for treatment, and it happened during pitching a game. He has no previous history of elbow or shoulder injury and no pain with hitting or throwing from first base, only pitching. He was tended to palpate primarily over his ulnar groove with a dull, achy soreness. Range of motion and muscle strength were equal, and he had no laxity with the valgus test, and no pain over his UCL with palpation or throwing at this initial visit. Our initial plan was to limit throwing in practice and begin stim with ice or heat. Initiate phonophoresis to help with inflammation, kinesiotaping, and to examine his mechanics, which were quite terrible when you increase the distance. He did pitch one more time a week after his initial visit, after which he started describing sharp pains while throwing, at which point we removed him from pitching and referred to the ortho. Because the pain had localized over the UCL, doctor allowed him to continue playing first and ordered an MRI. When we start looking at the ICF disablement model, he was diagnosed with a UCL sprain. Under this model, we have body structures and functions. He had decreased power and moderate impairment. His activity limitations were a moderate impairment of throwing, participation domain, throwing limitations, and severe performance limitations with pitching, could not pitch. Environmental factors, the people listed below were facilitators to his rehab. He has signed a national letter of intent, which is why his college coach is included. And personal factors, he has never had an injury to his upper extremity, but has had previous season-ending injuries prior to this one. When we look at health-related quality of life, the most important thing we need to look at is addressing loss of function and participation and how it's impacting the patient and the patient's health status. And also we need to assess the patient's perceived loss of function impairments and how the interventions of therapy are impacting his overall health-related quality of life. Again, the patient has never experienced an injury to his throwing arm, has never had an upper extremity injury before, has never had any loss of function, and has a bright future in baseball through signing a national letter of intent to a D2 school. So we want to closely monitor how this injury is impacting his overall quality of life and psychological health. For the outcomes critique, I picked the Oxford Elbow Score. It was developed by researchers at the University of Oxford to measure outcomes of elbow surgery. It's a 12-item questionnaire and has 3 domains: function, pain, and social psychological. Has demonstrated good measurement properties, reliable and valid. And you can see the statistics there. It has good responsiveness, has a good reported minimally important change, and has demonstrated good internal consistency. I like this one because in the research that I found, it said that it could also be translated into other realms, not just of elbow surgery. That was the biggest reason in selecting it. Other reasons of selecting it, the length is acceptable when dealing with the short time available I have for rehabilitation in the mornings. I have about an hour for all of my rehabs in the morning here at the high school. The questions are appropriate for high school settings. can give good information on how injury impacts dealing with daily tasks. It's very responsive. And I like how the questions can give an idea of how the patient perceives his injury, how his injury is affecting his life. And you can see a couple of the questions posted below. How do you feel it is controlling your life? Or how would you describe the pain you've usually had from your elbow? It can give you good information. When we look at measuring the change in the patient, first you must obtain the MIC value, which we looked at the other slide. For the minimally important change for function was a 27.6, and one research found pain 21.7 and social psychological 24.0. And that is basically the threshold for change that we look for once we compare scores from one assessment to the other. And if they have met that threshold, we can see that there's been a significant change, whether it has been positive or negative. And that gives us an insight of how the interventions are impacting my athlete. When I looked at implementing the change or implementing the pro measure, the athlete will complete the pro measure at the initial visit and every 2 weeks, and then at discharge. I'm looking for a patient-centered approach. I want them to be in charge of completing it. I want them to be the focus of it all. I want they're going to be completing it on their own, at their own rate, throughout rehab. They'll receive the link because you can complete this online, whether it's on a computer or on an iPad or on their own smartphone. And the score is calculated automatically, and then we can document that within Sportswear or in their SOAP notes or anywhere else in their rehab plan. The biggest barrier that I face is time. Again, I said I have an hour, and I usually have on average 10 to 15 athletes or patients in here at any given time that are needing rehab and doing their therapy plans. So we're looking at patient time of completion, patient time, commitment to rehab with their other constraints, whether it's team meetings or schoolwork or anything like that. And then clinician time to score. Solutions to this issue were the selection of the pro itself. It is easy to score and analyze. It has a smaller number of questions, which decreases the perceived burden on the patient. Simple questions, again, decreasing that burden. And computerized format, that is one thing that we saw in some of the reading, that you can look at decreasing the burden on the patient and they're being more willing to complete it. Again, students are more comfortable with electronic formats, and all that. In the end, we have our citations.